Everyone is just trickling in through the really narrow pipe of the internets. Thank you so much for joining us today. Most of you know me already, and I'm the director for gender equity. Welcome back to the Gender Equity Education Series. This is our first session for the fall of 2024, and we're really excited. This fall, we're going to do a deeper dive into the concepts of gender and gender identity. We know that in many academic health centers, there's a Women in Medicine and Science program, and I have many counterparts who are running programs with those titles. But here at LCOM, at Lerner College of Medicine, we've been really intentional about calling this the Gender Equity Initiative, to be more inclusive, to recognize that there are many different genders and gender identities, and that it takes all voices and everyone's effort to create a safe working environment and learning environment for all the community members. So we're really intentional about that, and we're very excited to have Dr. Lorario come and speak with us today a little bit more about the gendered brain, and we'll get to that in a second. But I want to take a moment, as always, to recognize the fact that the Gender Equity Initiative exists because we have leadership that's supportive of gender equity and equity and inclusion broadly. So Dean Page is here with us. He's here at almost every event, even sometimes when he's traveling. So I'm going to give him an opportunity to say hello.
Thanks so much, Dr. Doherty. Hello, everyone. Welcome to the new academic year. I'm trying to count up how many years you've been doing this, Dr. Doherty, yes, I'm here to get to say hi, but also, as much as anything, I love attending these sessions because I've learned so much. So my gratitude to you and your role as Director for Gender Equity and the entire Gender Equity Steering Committee and the people who put this together. We've just had a chance to chat with our visiting speaker today. Look really forward to hearing this talk. So I'm going to pass things back to you, Dr. Doherty, but thank you so much for you and the team putting these together. And now I get to sit back and listen and learn.
Wonderful. Thanks, Dean Page, as always. So we're very excited because through efforts in the Office of Diversity, Equity, and Inclusion, especially Emily I. Marino, we now have CMIE accreditation. And if you'd like to claim the CMIE, there's a QR code to claim that's on the right side of this slide. And then there's also an evaluation that's on the left slide. Emily is going to put the links in the chat as well. We'll throw this slide up again at the end. And Emily is also going to email this to the attendee list, so you'll be able to access it there. But we're really excited about that. And then we do have the disclosure slide here. Our speaker does not have any financial conflicts of interest. A couple of other housekeeping things. There is live captioning available, and Emily will put that in the chat, as well as a link to sign up for our listserv. This is, if you're saying, I didn't know about that, I really want to know more about gender equity at the Lerner College of Medicine, this is the way to do it. Sign up for the listserv, and you'll get some regular emails. So now it is my pleasure to introduce our speaker for this afternoon. Dr. Z. Lorario is a licensed psychotherapist and a board-certified neurologist. They have a specific interest in bridging gaps between the LGBTQAI plus community, neurologic disorders, and mental health care. In their psychotherapy practice, they treat patients who experience treatment-refractory dissociative conditions and their overlap with complex PTSD, borderline personality, and functional neurologic disorders or psychogenic neuroleptic seizures. Their academic work regarding transgender healthcare and functional neurologic disorders has been published in various peer-reviewed journals, as well as Scientific American, Social Work Today, Psychiatric Times, and featured quotes in the New York Times. Dr. Lorario is a co-founder of Greenberg Pride, a social activism organization in Tarrytown, New York, that offers clinical support, consulting, research, and academic writing, youth mentorship, and events. And we are so happy that you're here to speak with us today. Dr. Lorario, the floor is yours.
Thank you. I appreciate you putting on this great programming and very stoked to kick off the series for the fall semester. I'm just going to share my screen here. And here we go. You'll see that I am currently going through a legal name change process. So my name's going from Mackenzie to the letter Z. I'm currently providing psychotherapeutic services and transgender healthcare through a social work degree and doing a lot of advocacy work in the field of neurology to promote better inclusive care of transgender people in neurology, as well as to recruit and support trainees who are entering the field of neurology who are identifying within the transgender umbrella. Here are some financial disclosures that I have that didn't meet the criteria on the slide that was presented before. I do think it's important in research and academic spaces to consider a positionality statement as a disclosure, as long as everyone involved is comfortable doing so, as some of these are protected identities. I am transfeminine and I am non-binary. I use she, they, or neopronouns like they. Objectives for this will be to quickly just go through the terminology because it sounds like you may have already been exposed to that, but to also put my community-based approach and personal lived experience trickling in there to define things maybe to a greater degree than they have been before. We're going to talk about neurological conditions, which overlap with a lot of other medical and professional specialties, to particularly talk about minority stress and how that interacts with neurological conditions, how certain pharmacological medications used to treat common neurological conditions have specific salience to neurological conditions, and the emerging literature that shows that transgender people and other gender diverse people have increased rates of neurological conditions. Some interests to increase gender affirming healthcare, removing barriers, and creating affirming clinical spaces can also be addressed, and talk about what future could look like in areas where there are gaps. I really want to make the distinction between sex and gender because this is often conflated in clinical research and neurological practice, where sex is assigned at birth, it's male or female. Commonly, intersex is not assigned at birth, but now in some places can be added to a birth certificate for those who identify as intersex. These are based on biological characteristics, and therefore there's a biological basis to them based on hormones, genetics, or physical anatomy. Sexual orientation is not in any way overlapping with gender identity, as somebody who is transgender can identify as any sexual orientation. Gender is a sociocultural construct. This is something that varies over time and within cultures within the same time period. As an example, 100, 150 years ago, the color pink and high heels were considered gentlemanly in the United States. Obviously, the opposite is true today. And there are various indigenous communities within the United States and elsewhere where third genders or other gender diverse identities are more accepted than they currently are, which is a systemic socialization of a very binary model of what gender and sex is. People who identify as transgender do not necessarily identify as non-binary and vice versa. And there are a lot of non-binary identities. So if in clinical practice and research, we are not evaluating non-binary identity, we may be missing many people or misclassifying many people who identify as non-binary but not transgender. I want to specifically touch on gender euphoria because it's a terminology that's recently entering the peer-reviewed literature. It's community-derived and has been around for some time, but to put that community terminology into the literature is important because this is not really recognized within the DSM or the ICD classification. But many people who are transgender do feel that this experience is more characteristic of the transgender experience than what is currently defined as gender dysphoria, which is pathologizing. Gender dysphoria right now is a necessary evil because it's used to get insurance companies to pay for a lot of gender-affirming healthcare. We talked about intersex people. I wanted to note that in recent studies that Interact, a national nonprofit advocating for the rights of intersex people, they were involved in this study. It looked at common intersex conditions and also transgender identification. And there is a common overlap between trans identifying people and intersex identifying people. One of the most studied intersex variations that is present in the literature is congenital adrenal hyperplasia, and we may touch a bit on that later, and its relevance particularly to cerebrovascular disease, as hyperandrogenization may have some effects on some stroke risk factors that could be novel, not seen in other patient populations. We are seeing increasing identification as transgender over time and also within younger generations. Something that is not commonly focused in neurological practice research or clinical research as a whole is the intersectionality between transgender identity and other marginalized communities, particularly Black, Indigenous, and other people of color, is something that should be specifically addressed in demographic data collection for clinical and research purposes, because many in the transgender community also identify from the BIPOC communities. If you don't know about the Movement Advancement Project, definitely check it out online. Keeps very up-to-date, basically assessments of what legal protections are or are not available across the United States. Even in states that are negatively rated here, in many places that have major cities that are more progressive, there might be local protections. This is not just relevant to practitioners and patients, but it could also be relevant to your academic institutions who are interested in recruiting gender diversity to your institutions. There might be barriers to trainees receiving healthcare that is necessary for them to be included and fully participate and accommodated within the workplace. The gender minority stress and resilience theory, originally described by Elon Meyer in 2003 and then re-updated in 2015, is one of the prevailing frameworks for describing community-specific stressors faced by the transgender community. There are now multiple validated instruments in the transgender community, both in adults and adolescents, in multiple languages, and very recently, earlier this year, in the intersex community, it's been adapted there as well. So this discusses both stressors and resilience factors that the cumulative weight and interplay of those will end up driving biological and psychological consequences. Proximal stressors are interpersonal. This can be for people who are in or out of the closet in terms of concealment, anticipated rejection, and internalization of stigma, which gender dysphoria is particularly thought to be a proximal stressor from that internalization. Distal stressors can range from things that are institutional, interpersonal, or environmental, and they're listed here. Resiliency factors are also proximal and distal and can be actually self-advocacy, expressions of community, and then having more healthy lifestyle behaviors, because many people in the community do resort to adverse coping mechanisms like substance use and other lifestyle behaviors that might affect health outcomes. Here are some other distal resiliency factors where we can, as providers, really advocate for the community, advocate within our institutions, train people in these areas, mentee transgender people who are willing and interested in entering professional practice. This is from a recent publication we had, and it just describes some of the neurobiological outcomes and other biological outcomes we see from health disparities, particularly related to minority stress in this community. Chronic stressors have been described to have some amount of neurotoxicity, including network dysregulation between the cerebral cortex and limbic areas, decreased volumes of the hippocampus, which may be relevant later when we talk about cognitive decline in the community. And then other physical morbidity, mortality, particularly in cardiovascular disease, which has been relatively more studied in this community than other specialty areas of healthcare, and showing that there are increased rates of cardiovascular morbidity, mortality in the transgender community. And it has been posited by the American Heart Association that this may be partially related to community-specific stressors. Here's just an overview of gender-affirming medical therapies. Not everybody desires medical transition, but the majority of people do undergo some form of medical transition. We should keep in mind, with more and more people identifying as non-binary, that there might be more ambiguous or intermediate gender expressions, including medical transitions, that may have, I guess, less familiar gender expressions than we're used to in the male-female binary. So that is something that may result in microdosing of certain types of hormonal therapy, or even specific surgeries that are meant to present with an ambiguous gender expression. The reason why I'm also discussing this is because gender-affirming hormone therapy, as I said before, does interact with certain neurological medications. GnRH agonists, puberty blockers, are important because they're being banned in many areas of the country right now. These are given to adolescents who are deciding whether or not to initiate more permanent medical transition. And there was some controversy a couple years ago because there was a black box warning label from the FDA placed on these puberty blockers regarding increased risk of idiopathic intracranial hypertension. This was based on just basically a couple cases of people who are transgender on these puberty blockers who developed IIH. That is unclear because it was not controlled in any studies in any way. A follow-up study from Sweden that followed a larger cohort of transgender people did not find that there was an increased risk of IIH compared to cisgender people. We see a lot of healthcare avoidance in the transgender community. The US Transgender Survey is a very large national survey. If you are not aware, another update was presented in 2022 as a survey, and some of the preliminary results have been published. But if we are not affirming of gender, there is going to be a lot of healthcare avoidance, not just for gender-affirming healthcare, but many other areas that influence health outcomes. And these types of issues are highest for people from Black, American Indian communities, as well as Hispanic communities as well. If we increase affirming environments, such as using interventions as simple as using the chosen name and pronouns, this could actually be life-saving and shown in multiple studies, including the ones that are listed here. These are ways to increase affirming environments. It sounds like from speaking with your institution, you're already doing a lot of these things. I think accountability and how an institution, department responds to issues is the most important thing. I think a lot of transgender people are very aware that there might be issues, there might be misgendering, there might be some mistakes made, but if it's meant with defensiveness, if it's meant met with non-accountability, not apology. This is where I think a lot of the issues comes in, because that's where a lot of the learning takes place. Practice these things, practice it with allies, so that a lot of the burden is not placed on your transgender colleagues or peers, but actually exposure to transgender colleagues and peers will improve the comfortability of working with transgender patients in both clinical and research settings. This is from the World Professional Association of Transgender Health. This is the transgender health organization from an international perspective. They published the standards of care. The version 8 was recently published within the last couple of years. There is no availability of neurological practitioners. With my most recent search of the member directory earlier this year, this needs to change. I'm doing a lot of advocacy work with various national and international neurological organizations, which are starting to set up clinical research, advocacy, mentorship of trainees, and starting to create recommendations for neurological practice, with the hope that we can expand this out to transgender-specific organizations, so that there is more access to affirming neurological care for transgender people. A scoping review by Nicole Rosendale from UCSF was published a few years ago. At that time, there was very little data on transgender people. Most of it was on regarding cisgender gay men, particularly the neurological sequelae of HIV. Since then, there has been actually a large amount of data that's being published, a lot that's still in peer review or various phases of the publication process. The areas that are most studied are currently stroke and sleep and headache. We're seeing a lot of other areas with emerging data as well. There are various sampling issues. Finding the correct way to identify transgender people is very important. A lot of prior data uses diagnosis codes, particularly for gender identity disorder, or other outdated ways of identifying transgender people. A lot of the data doesn't control or even assess gender-affirming hormone therapy, which, as we're going to see, can interact with neurological presentation and other medications that are prescribed for neurological conditions. So that's one issue. Having community trust and input into the process from start to finish is really important, and is often left out because maybe there might be an unawareness of how to identify transgender experts who are within the community, and that is something that should be better addressed in future research. A lot of the research is non-probability sampling because it can be unethical to randomize transgender people to not undergo or have gender-affirming therapy as part of their treatment. Migraine has been studied, as we can see here, that and we're going to see time and time again, a lot of the data is retrospective or cross-sectional. But in these studies, we're seeing that gender-affirming hormone therapy and transitioning can influence frequency of headaches, disability from headaches, and gender-affirming hormone therapy actually could potentially reduce the frequency of headaches in people who receive gender-affirming hormone therapy. These changes tend to take place in both transfeminine people on feminizing hormone and transmasculine people on masculinizing hormones. And we also see here that, just like in cisgender populations and the general population, migraines are a very commonly encountered diagnosis among transgender people. So it's something that is important to study and to begin treating patients, counseling them on how gender-affirming hormone therapy may influence their headaches, and then how gender-affirming hormone therapy may interact with commonly used medications that treat migraines. Minority stress does and potentially can influence neurological conditions. This study from PRIDE study, which looks at a large number of LGBTQ identifying people, had 41% of its population sample identifying as transgender. They looked at migraine disability and found that those with a history of trauma or discrimination, two commonly known minority stressors, at least an unadjusted analysis, those minority stressors were associated with more moderate to severe disability. And this should be looked at further in studies, particularly using validated survey instruments like the Validated Minority Stress and Resilience Measure. Seizures are more common among transgender people. This was a large sample from the Medicare claims database. It did use ICD-9 codes to identify transgender people, and there was no pharmacological data, but epilepsy and various other chronic health conditions were found to be more common in transgender Medicare beneficiaries than cisgender ones. There also was a recent publication in JAMA Neurology from the National Health Interview Survey that was just published a couple months ago that did ask questions about sexual orientation and gender identity, and they did find that epilepsy was over twice more likely among LGBTQ identifying people than those who are cisgender and straight. So that does confirm this. It did not look at gender affirming hormone therapy, which is important as we see here. Collaboration with a hormone prescriber and primary care prescriber or endocrinologist is imperative when prescribing neurological medications. You can see that this is for epilepsy medications, but there are also a lot of overlap with commonly used migraine preventative agents. A lot of the newer medications like the calcitonin gene-related peptide agents do not have as many drug interactions, so they may be good medications to consider. And those who have otherwise adverse events or interactions on these older agents. Estradiol is a particularly important one to mention because it is known to have proconvulsant activity and can also lower levels of commonly prescribed anti-epileptic agents. When we prescribe headache preventative agents and epilepsy medications, this could also lower gender-affirming hormone medications. So checking hormone levels and levels of seizure medications is important when we have patients who are on these drugs. One thing that I see time and time again is this concept that if there is an adverse event or side effect from hormone therapy, that for some temporary period or long-term period, hormones should be halted. This is an issue because these hormone medications have real benefits to the patient that are evidence-based. They reduce risk of suicide, other mood disorders that influence medical health outcomes. So it is not benign to stop these medications even temporarily. This should be done with an informed consent process, discussing the risks and benefits of even temporarily holding medications, and make that decision along with the patient so that there is agreement in which the best path forward is. And I know many transgender patients I work with will say the words, "I would rather die than stop my gender-affirming hormones." So keep that in mind as we discuss risks of hormones, because we need to take into the context of the whole patient, including the psychological consequences of stopping hormones. Cerebrovascular disease is being shown that is likely more common among transgender people as compared to various types of cisgender samples and the general population. This has been now shown in several different databases, and the growing evidence is that although there is a small increase in cerebrovascular disease outcomes, that there is an increased risk among transgender people. This risk may be more likely to occur in feminizing hormone therapy in trans feminine people, particularly after 6 years, which has been used as a time metric in multiple studies now, but overall, it's the long-term consequence. In one study using Kaiser data, which did have linkage with EMR and prescription data, that risk difference among transgender versus cisgender women was 15.3 per 1,000. And so I would like to move to the next slide, which is one of the most rich data sets I've seen from the STRONG study, looked at a very large number of transfeminine patients over a large period of time on feminizing hormones and matched to cisgender controls, and found that injectable estradiol has the most risk of clotting, which is the same as seen in other clotting disorders like venous thromboembolism. And we also believe that transdermal formulations, low dose of estrogen, may have lower risk of clotting disorders, but that is based on expert opinion. And as we see here in this incident survival curve here of stroke, we do see that after about 6 years of feminizing hormone therapy, that those who are transfeminine receiving estrogen therapy, their risk of stroke diverges from those who are controls, both cisgender males and females. A lot of the data so far looks at cardiovascular disease outcomes. They don't particularly look at cerebrovascular disease, but particularly the effect of gender-affirming hormone therapy on various cardiovascular risk factor outcomes. And as we see here, those who are transgender men or transmasculine may have effects on lipid profiles that we do not know necessarily what the clinical relevance of those are. There may be small increases in blood pressure with gender-affirming hormone therapy, but clinical outcomes with that change is not really studied, so we don't know what the clinical significance is. We do see a potential increased risk of ischemic heart disease and venous thromboembolism, but how that relates to actual stroke is unclear, particularly in patient populations that have a patent foramen ovale, where there might be a conduit between the venous and arterial systems. Those who have cerebral venous sinus thrombosis, is that risk increased in transgender people similar to lower extremity venous thromboembolism? And pulmonary embolism. A study that's being done in UCSF, which is collecting registry data on their LGBTQ in patients with stroke, is showing that STIs are maybe more common in their transgender patients who are hospitalized with stroke. However, transgender people are more likely to be tested for STIs, so there's a potential bias in testing there. Multiple studies show there are increased rates of substance and alcohol use, tobacco use among transgender people. This is a particularly big issue because tobacco companies now do have pride advertising, particularly targeted to LGBTQ youth. So that is an important area of advocacy where there's federal funding to combat that. COVID did affect TGD people more severely with the pandemic. Mental health can affect access barriers. Economic impact can affect access barriers. There's increased rates of post-COVID syndrome. So there's a lot of issues there. And as we know, COVID is a unique risk factor for stroke. Some gender-affirming medications may interact with certain medications used to prevent stroke. There are cases out there where testosterone in particular can affect bleeding risk with warfarin use, and also simvastatin levels may be decreased with spironolactone, which is a common medication that is used as a testosterone blocker in transfeminine people. Sleep disorders are more likely to be common in transgender people. This is from the Optum Clinformatics DataMart database, which is a rich data sample assessing transgender people, particularly youth, young adults and adolescents. And we see that there are quite high odds ratios for insomnia, sleep apnea, and other sleep disorders when comparing cisgender youth to cisgender research participants in the sample. And then those who are receiving gender-affirming hormone therapy had significant decreased odds of having sleep disorders. It's unclear what the nature of that association is, but there could be some relation to mental health outcomes, to more increased socialization in people who are receiving gender-affirming treatment, but that needs to have further study. Dementia risk factors overlap, as you can see, with a lot of cerebrovascular disease risk factors, and these are more common in transgender people. This is a study from One Florida Clinical Research, and it shows that there are higher rates of risk factors in transgender individuals, and these are very common, including smoking, alcohol use, depression, hypertension, obesity, and sleep disorders. But specifically, subjective cognitive decline that doesn't reach the diagnostic criteria for dementia is more common among transgender people and is quite common among the community in general. I think with long COVID, post-COVID syndrome, and other functional cognitive issues in transgender people, it's unclear exactly if those contribute to the subjective cognitive decline. So more needs to be studied, but there's some thought that minority stressors and chronic stress may also be attributed to this, perhaps with effect to the hippocampus, but this is completely wide open. And do other chronic stressors like racial minority stressors contribute in a additive way to those transgender people who are white identifying? Functional disorders are more common among transgender people. This was from a scoping review that we published recently. A lot of the data is from case study or series. So this is a lot of hypothesis generating data. The most commonly studied functional disorders are fibromyalgia and FND, or functional neurological disorder, previously categorized as conversion disorder. The age of clinical presentation in these studies are on the younger side compared to traditional FND samples in the general population. It's unclear why that is. FND in this registry of patients in Melbourne, Australia, is showing that there is a higher rate of transgender identifying patients in their FND specific clinic than there are in the general population based on census data. There is some signal that somatoform disorders and fibromyalgia is more prevalent among transgender people when compared to cisgender people. And there is an additional study from an Israeli cohort that also looks at fibromyalgia and shows that there may be changes with gender-affirming hormone therapy and rates of fibromyalgia diagnosis. And fibromyalgia is more common among transgender people as compared to census data in Israel. Over the pandemic, there was a very large rate of functional tic-like behaviors among youth across the world. It's thought to be a social contagion effect over TikTok, particularly where Tourette's content that was viewed by the patient was associated with development of a functional disorder that was functional tics. We looked at a study from Calgary that had a 42% transgender identification within their FND clinic sample. And it looked like gender identity was not directly correlated with disability or psychological quality of life, but was instead mediated by mood outcomes such as depression and anxiety. And it is unclear why this was such a large percentage in this sample, but a significant minority of FND clinics around the world noted overrepresentation of transgender and non-binary identification in their samples. And this is being studied as we speak in various studies now around the world. In case reports and series, including one I published along with a group at UT Southwestern, shows a pattern, but this is non-controlled, so it's just hypothesis generating, where we see concealment of identity being in the closet or receiving non-affirmation can initiate symptoms of FND, and then when the client or patient's symptoms are affirmed and they receive affirming support, that can lead to improvement or resolution of symptoms. So that needs further study. I show this picture because a lot of people don't know who this person is, but they should. That is Rudy Giuliani. There is multiple pictures and videos of him cross-dressing. I am not saying he has any movement disorder or Parkinson's disease, but the point is often when I show this picture, people laugh, including doctors. And we may see more and more people in early phases of transition or who are otherwise expressing gender diversity in our clinics. And we need to meet that with sensitivity and have more exposure to that. So it is not something that looks atypical or out of the norm, but it is more normalized. And we do see with some dopamine agonists that it can unmask gender nonconforming behaviors when they've already existed. It doesn't cause the gender nonconformity, but it can be distressing to a person when they're in the closet, when they start cross-dressing more during the experience of being on certain Parkinson's medications. Multiple sclerosis is another disorder that may be increased in the transgender community, but there are sampling issues like using ICD coding data, like in the other studies. This is a retrospective study from the UK where the adjusted race ratio for multiple sclerosis diagnosis was 6.63 among transgender women. In the NARCOMS registry, which is a North American MS registry, we also see that there were actually quite a number of transgender people. Half of 1% of the sample was transgender identifying, and those who were had less comfort discussing sexual health with their neurologist, which has been important because MS can cause genitourinary issues in those with spinal cord disease. The LGBTQ medical education literature is lacking. How we incorporate more transgender people and non-binary people into the training, but also as the facilitators providing that training is important. Standardizing the training, getting people who aren't already familiar with this content into the training is important. And as we can see here, there is a dearth of information on non-binary people in this systematic review that I wrote here. Inclusion of transgender trainees is important. We need to have specific accommodations for them in the workplace so that they can receive the appropriate affirming health care, both mental and medical care, as they are supported in their training process at institutions. There are specific needs of this community, and those need to be addressed. When there are issues, there should be anonymous reporting. There should be a written policy already in departments and institutions regarding gender transitions. If one doesn't exist, there are many professional organizations out there that can provide help in writing those. Having gender-neutral facilities and dress codes is imperative. Some institutions in the United States have very strict binary sex segregated dress codes that will actually be technically discriminatory of the transgender community. So that should be something that's looked at as well as not just the facilities, but the dress codes. This is in a publication we have in review right now, but it shows various approaches, particularly focusing on intersectionality, community input, and focus on the environment and how that influences neurobiological outcomes and how we can reduce those environmental stressors in driving neurological conditions, and how prevalent they are and how they're treated within the community. We as providers should be advocating for this. It is not something that's commonly done until recently among neurologists. In fact, a lot of the advocacy for healthcare in the transgender community are being provided by people who aren't healthcare providers at all, who are in professional practice outside the healthcare system. So that is something that can be improved upon. I think some of these other things I've discussed here, but recruiting out providers is important. People who are publicly identifying, who state that publicly and have that identity as part of their practice is important so that we can recruit trainees and gender diversity into the professions. Just to summarize before I take questions, These are often questions I've had when presenting these lectures, so I just wanted to throw them up there and dispel them. There are real neurobiological consequences of minority stress and gender-affirming hormone therapy. There are increased rates of neurological conditions in this community. We don't know why. It requires further study and education and awareness. There are ways we can already improve this community trust to recruit people who are transgender into practice, into research, both on a provider and researcher level, but also on a patient and participant level. And it will improve not just neurological outcomes, but drive all these other equitable outcomes that we have seen in other areas of study and practice that are common in the transgender community. Here are some areas where you can seek additional resources if you are looking for collaboration with transgender-specific professional organizations. And here are my very large group of people who have helped me, who are fabulous allies, to get some of this research out there, perform this advocacy work, and support me in my own research and advocacy work. So you can check me out online. You can email me here. Again, thank you for having me. I'm available to answer any and all questions.
Thank you so much, Dr. Lorario. That was a lot of information. I think there's so many different ways we could dig into that, and I really appreciate your perspective and appreciate all of what's really, I think, in part advocacy work. It's scientific exploration, but it's advocacy. And so thank you for doing what you do. We do have several questions, probably more than we'll be able to get to, but we'll go through some of them. So one of our attendees asks, says there, what advice do you have for people who are interested in studying or researching the overlap of trans and non-binary identity in specialties that may not be commonly associated with gender diversity research? And they name rheum, derm, PM&R. It's been my anecdotal experience that many friends in the community have a higher rate of connective tissue problems, and I've always been interested in how to dig deeper, but don't have an idea how to get started.
Yeah, it sounds like this person may be a rheumatologist, and you're right. There are other conditions here that overlap and are more overrepresented in the transgender community with conditions that I didn't have the time to get into. That includes hypermobility syndromes and connective tissue disorders. Autism is another common one that comes up as a question a lot. Again, these things are more common in the community. It's unclear why. There are a lot of barriers for studying this part of the community. I think a lot of it has to do with community trust. Qualitatively in research, we're seeing that time and time again, there is non-affirming treatment of the community in research. And if the participants are feeling like they're not being affirmed, like they're being treated with offensive treatment, there's been frank horror stories that I hear of where I could understand why the transgender community is not participating in certain types of research with certain institutions or researchers. That's going to create barriers to care. And I think they need to see themselves represented in the research. So a lot of times what I see in the peer-reviewed literature is a study is done. There is no community input directly from the transgender community. It gets into the peer review process, and a peer reviewer editor catches that. And then we have to go back and, get somebody from the community to come back and provide an implicit bias review, or even worse yet, find definite methodological issues with the study. And therefore, further analysis needs to be done. And then the question comes up of, does that contribute to authorship? Does that transgender person providing their community-specific expertise qualify for authorship? Meaning, does their review of the manuscript, does their editing of the manuscript, if it requires input into the methodological aspects of the manuscript, if they write part of the manuscript that has to now do with community-specific areas that weren't initially addressed. These are all issues that I see coming up, and I see it being addressed different ways. But all it says is we're now playing catch up, so we need to be proactive. Any study moving forward needs input from the community, whether that's an advisory board or whether that's including investigators or trainees who are part of the community. We need people who are able to communicate that specific community expertise. And I think this is similar to many other marginalized communities. Racial minorities, it is becoming or is best practice to include people of color in research that involves their communities, because when we see that's not done, there have been ethical issues brought up time and time again, many of which are well known in why we've set up ethical board review for research. So I think setting up standard research practice for catching that earlier in the IRB review will be important. Including transgender community members in ethical board review will be important. Hiring people, recruiting diversity intentionally will be important. And then when issues arise, respond to that in an accountable, transparent way and actually act on it to improve the experience. Because a lot of times what I see is there are liability concerns from certain institutions that will, result in some stonewalling where it's not adequately addressed as a proportion response to the infraction, whether that's mild or major of an infraction, at least how it's perceived by the transgender community member. And how that lived experience is interpreted and incorporated in the response is important. I could talk about this for days, but having forms, demographic forms, research forms, having input directly from community members is important because it shows that those things are being thought of beforehand. It shows that there won't be misclassification by having non-community input into how those forms are distributed and written, particularly because in the peer-reviewed literature and in diagnostic classifications, when we as scientists put together data identifiers, it is already, as of today, outdated as to how the community themselves identify. So therefore, we already are playing catch up on another realm, which is demographic data collection.
Thank you for that. I have two questions that are around the overlap between transgender identities and neurodivergence or neurodifferences. One of them is about data around neurodivergence in transgender and gender diverse youth, something that this person has noticed anecdotally in their work with trans teenagers, but not sure how much it's been studied. This person says, I've assumed neurodivergence could be possibly protective in helping these youth not be as self-conscious of presenting as gender non-conforming in adolescence, but not sure if this association is real. And then there is another sort of related question about this concept of autigender, and I don't know if I'm saying this right, but an overlap between autism spectrum disorder and transgender identification, and wondering how distinct this is within the transgender category based on your experience, and are patients with this combination distinct in terms of their needs and clinical approaches? So that's a lot of questions, and we're going to run low on time. I'm sure you have some thoughts on that, though.
Yeah. So I think it's a good question and a common question. I think the available data shows that in samples of transgender people that autism is more prevalent. In samples of people with autism, transgender identification is overrepresented. So we're seeing, that this may be a real signal in terms of experience with the community. We are seeing that, and just in terms of experience. It's not fully clear why that is. I think for both transgender identification and neurodivergence, there's this fear of biological essentialism of what is the purpose exactly of research if we are to identify biological or neurological basis for neurodivergence, and then how will that ethically be used over time? Will it be used to prevent neurodivergence or transgender identity if there are certain neuro or biological basis to these identifications? And so I think the move is from saying that these are pathologized to these are just part of a spectrum. And we have, because of social pressure, been pathologizing the spectrum and pressuring a binary that doesn't, I think, exist biologically and is more of a socio-cultural basis. So I think, to incorporate more affirming care to neurodivergent people is about accommodations. The same thing I just said for transgender people applies. How are we asking about the data? Are we including people from disability spaces or neurodivergent spaces into how we approach their communities in research and clinical care? Do we intentionally recruit trainees and peers who are from this community? Are we increasing exposure and advocacy? All these things are there. I, seen several different, ways of potentially explaining, which are all hypotheses, why more people who are transgender identify as neurodivergent or are diagnosed with autism. It could be used in screening instruments that don't have norms towards this community because they were all validated with cisgender populations. There could be something unique about the social dysphoria that is experienced by transgender and cisgender people, because social communication is something that is affected between neurotypical and neurodivergent people. So that's another explanation. When I look at F&D samples, there's been recent studies that show that sensory processing could be an issue because people with F&D have sensory processing issues, as do people with autism, and then also people who are transgender. Assigned female at birth people who are pressured to present femininely, to wear clothing that is uncomfortable, that is tight, that might not be comfortable to them from a sensory standpoint, may also not be gender affirming if they are transmasculine or non-binary. There's a lot of potential thoughts that are out there, but the question is, should we be studying this versus just accepting this as diversity? Or if we study it, how do we make it as affirming and accommodating as possible?
Thank you. Here's a big question, but I think it's an important question. This person asks, what can I do as a trans med student to advocate, especially for youth?
I think there's a lot you can do. At the American Academy of Neurology, we created a gender equity working group, and we have people from all specialties involved. It's not just neurology, but a lot of us are people interested in neurology or an adjacent field. You're more than welcome to join. Just reach out via email and I can connect you. I think finding the right mentorship to support your career, whatever that takes you, is important because, as we said, we need you. We need you. There's so much work to do, and finding those allies, because let's face it, a lot of them will not be transgender faculty members, particularly people in leadership positions. So you will need allies. In finding people who know who those allies are, connect you with the affirming people who will support you, be affirming. That's important. I think you having a voice in this is important, and those people can help facilitate that. I think that doing work in advocacy spaces and professional organizations is an important thing. Doing it within your department or institution is an important thing. The pressure to be tokenized will be there. Once you're out, there will be a minority tax. There will be requests for you to do this work, often uncompensated. So working with an affirming chair or dean or mentor who will give you the appropriate compensation, whether that's acknowledgement as an investigator or author, whether that's named credit or time off or accommodation so that you can do this extra work, because it is outside the responsibilities of any cisgender or transgender medical student. A cisgender medical student is not expected to do training, education, awareness for the community. So it should be accommodated by providing the time and the resources to do that work, and knowing, who will be the allies and helping you get that will be important. As I said, we need you. You will be supported and embraced in doing this work, because this work is something that is at top priority for people in diversity, equity, inclusion spaces. But I also don't want you to burn out. There will be, once you're out and start doing this work, there will be requests from many different places to have the appropriate boundaries to take care of your mental health. That will be of the utmost importance, because if you're not taking care of yourself, you can't help anybody. And the minority stress is real. It happens in medical professions. It happens to medical students. I mentor a lot of medical students. There are a lot of specific issues in the disclosure process and the transition process. Talk to as many transgender people who are doctors as possible, because there are pitfalls in doing it. We just published a transition guide as part of an article earlier this year in the Neurology Resident and Fellow section. Take a look at that. We have had a lot of failures in transition and a lot of successes. Learn from our experience. And these are all things that I think you should think about. You may already be out, you may have already transitioned, but definitely if you want to do this work, it is something that there's so much work out there. You will be able to do it. It's just deciding what you want from your career 10 years from now, and who will be the people that facilitate you to get to that goal 10 years from now.
Wonderful. Thank you so much, Dr. Lorario, for sharing all the work that you're doing, your wisdom, your passion. We really appreciate you being with us today. The next session, I want to remind folks, is November 13th, and Kel Arbor, who is with our local Pride Center of Vermont, will be talking with us. The title of their talk is Working with 2ST LGBTQ+. And if those are new initials for you, then you need to come to this talk. And we'd love to have you. Also, we can claim CMIE for this session, and the links are all in the chat there. Thank you so much for coming. We really appreciate you. Glad that we're back in the fall semester now, and we look forward to seeing you in November. Take care and have a great day.